Good afternoon, everybody, and welcome to this joint webinar that's being put together between Addiction Professionals and DDN. And today we're going to look at some of the issues behind the increase in alcohol-related deaths and look at perhaps what some of the causes might be, and perhaps through the auspices of the questions and answers, maybe even start to come up with some ideas about how we may address this in the future. I'm Steve Brinksman. I'm the Clinical Director with Addiction Professionals. And today with us, we have Kate Hall, who's the Head of Operations of the Substance Misuse Division of the Greater Manchester Mental Health NHS Foundation Trust. We have Kieran Doherty, who's the Head of Quality and Governance from Inclusion. And we also have Aimee Carer, who's a person with lived experience of alcohol use disorders, and she's going to be talking to us later. So I'm just going to give you a short introduction, and then we'll pass that over to Kate and Kieran for the rest of the presentation. So basically, I'm just going to start with a statistical update. We're going to be using some figures from the Office of National Statistics, which we've been given permission to use for this webinar. And these were presented at first to the all-party parliamentary group on alcohol harm. Next slide, please. So what we're basically looking at with this slide set is the alcohol-specific deaths data for 2019, and then there's some provisional data for the first 3 quarters of 2020. Next slide. And I think it's worth bearing in mind, these are alcohol-specific deaths, so they only include conditions where the death is a direct consequence of alcohol misuse. So that is wholly attributable to the alcohol misuse. So actually, these are really almost a tip of an iceberg because there are so many other conditions that alcohol plays a significant factor in. Next slide, please. So if we're looking at the deaths, the top rate is males and the bottom one is females and the middle one is the combined figures. And the key thing here is to note that there has been quite significant 11.3% rise since 2001. And whilst there was a slight drop off around about 2008, 2009, 2010, that's now started to correct and has been consistent over a long period of time. The alcohol specific death rates for males about twice that of females. Next slide, please. And interestingly, we have had a decrease in alcohol-specific deaths in Scotland, which is the dark blue line at the top there. However, deaths in Northern Ireland have increased significantly, and deaths in Wales and England have increased, albeit more slowly. Next slide, please. So looking at the provisional data for the first 3 quarters, in fact, of 2020, there has been a quite significant increase in deaths in that area. And approximately 5,460, or 5,460, not approximately, were related to alcohol-specific causes in the first 3 months. And that is actually a 16.4% increase over the first 3 quarters of the preceding year. Now, there's been a lot in the press about increased alcohol consumption during the pandemic. However, the vast majority of alcohol-specific deaths are not acute deaths. So actually, although there's a significant increase here, these deaths relate to people's drinking patterns in the years running up to that. Next slide, please. And if we look at that graph, these are all the quarterly data going back to 2001. And if we straighten those curves out, I think we can see that there is, a steady increase there. So what are we going to do to flatten that off and hopefully even decrease it? And those are some of the questions that we're going to look at today and discuss. Alongside that, I'm going to give a little plug for the next RCGP and Addiction Professionals Combined Conference, which will be taking place at some point next year. And there's going to be a very strong focus on drug and alcohol related deaths. So if you find today interesting and you want to take this further, hopefully we may see you all about that. And what I'm going to do now is hand you over to Kate Hall and Kieran Doherty, who are going to do a joint presentation. And then after that, we'll all look forward to hearing from Aimee. Thank you.
Thanks very much, Steve. Okay, we were asked just to talk through these alcohol-related deaths that have been occurring, just taking a service provider's perspective on it. Next slide, please. I suppose the image, sorry, if you could go back to the previous slide, please, Sapphire. I suppose one of the questions we have to ask is, how do we get here? This has not just been as Steve was saying, this is not just a pandemic thing. I think there's been a gradual erosion over the last number of years, which has led us being here. And if we look at some of the background to this, I think it relates to a number of issues. One of them is clearly changes to commissioning, and I'll come on to look at that. The move to competitive tendering, where there's less long-term view in regard to how we achieve what we want to achieve. I just have to say, while we're talking about local authority funding here, I have to be clear that there's no criticism here in regard to the local authorities, who I think are doing a very difficult job in difficult circumstances. But there's no doubt that there has been year-on-year reductions in local authority funding. So therefore, the resources going into drug and alcohol services, but more specifically alcohol services, have reduced year-on-year, going right back to 2013. I think another factor has been the move to integrated substance misuse services, and I think what has happened there is that we've lost a lot of the alcohol specialism, both in regard to skills and in regard to people, and I think that has had and again, I suppose the point I would make here is that I'm not saying that integrated services can't provide good quality alcohol treatment services, but the information coming through is generally they don't tend to be. The quality of provision, the outcomes have reduced, and there's a number of factors for that. You know, less outreach work. There's clearly less work on primary care. There's been an erosion of pathways as services have become very opiate focused within a single or a couple of hubs. But you know, deaths were increasing. You know, I think Steve has talked about the ONS survey for this year. Deaths have been increasing significantly over the past number of years. Kate, do you want to add anything in here?
Yeah, I think, as you say, Kieran, I think the reference to alcohol in the NHS long-term plan really defines the focus as being on trying to reduce the number of A&E attendances, and that would suggest that the real challenge is around the number of presentations in the acute sector that, as I think Steve articulated, is a real tip of the iceberg. And I think, you know, it feels very reactive, really, doesn't it, rather than proactive. And I think it's as though that's been a consequence of the changes in commissioning, the disinvestment, the changes to these services, as you've said, that have become integrated. And so it does feel as though we're almost reacting to something, you know, almost putting a sticking plaster over the gaping wound. I think that, as you've said, and I would agree, it's not about a criticism, it's about an observation from you and I, who've both worked in this field for many, many years, that, you know, we remember a huge increase in drug treatment, which was very focused on reducing the crime yield. And I guess the impact of that on an integrated service particularly felt quite stigmatizing for those service users with alcohol-related dependency. And I think that, as you've said, the separation from the wider health economy does appear to have exacerbated the existence in a silo, and that's what we have in terms of the feedback from services and from service users, is that alcohol isn't being used in isolation of past trauma, adverse childhood experiences, mental health issues. You know, we hear people talking about, I drink because of who I am, and that connection with those pathways does appear to have been impacted as a consequence of all those changes that you've explained.
Okay, can we have the next slide then, Sapphire? We'll talk about some of the specific factors here. And again, although we're talking about death today, you know, I think we do have to look at, it isn't just about death. This is about people's well-being. It's about the impact on families, criminal justice, mental health. You know, we could go right through that, but we're seeing that impact right across on the disinvestment in alcohol. Clearly, we welcomed the Dame Carol Black review, which came out recently. I think it made some really, really important points. I think one of the things that's important to point out about the Dame Carol Black review, it didn't specifically look at alcohol, which for me pretty much showed where people's priorities were. And I think that was, it could have been more rounded if it had included alcohol. And I think some of Dame Carol Black's recommendations, while many of them were absolutely great, I think there was a real lack of that link with primary care. And if we're going to attend to alcohol problems across our integrated care system, it needs to be working with colleagues in primary care, and that was a big gap in regard to the feedback from the Carol Black review. However, one thing she did say was, and again, this is across all SMS services, the prolonged shortage of funding for community SMS services has led to a loss of skills, expertise, and capacity. And I think that's felt more profoundly within alcohol-specific provision. I think over the last number of years, there's also been a loss in detoxification beds. Certainly in relation to, I work on the NHS, we have links with NHS detoxification centres, and the reduction of them over the last 20 years has been stark. And I think there's only five NHS detox units in operation now. There's also been a real drop in the number of people entering specialist treatment. PHE inquiry in November 28th said that between 2013 and 2017, there was almost a 20% drop in people entering specialized services for alcohol. And I think that reflects how alcohol service users perceive services. They don't see them as being set up for them, particularly when the move to an integrated model. They do see that they're going into essentially a drug service that does provide a bit of alcohol. And that leads to more people not engaging in services. Or what you then see is that by the time people do enter treatment, they're more complex. And that's certainly something that we see in our services, is that the people who are coming into our services now are really quite poorly by the time they get to us. We're not seeing the same percentage of people for early and brief interventions that we used to see. And, you know, a couple of the bits that we're doing recently, we end up doing the end of life care with people because they're so poorly when they come in that we're linking in with, you know, liver specialists and, you know, hospital-based services to help people navigate through. This all in turn has led to poorer outcomes. So we're not getting the outcomes for alcohol that we would like. The big factor one of the big factors to me is reduced links for primary care. And I think there's many factors for this, but there's no doubt that when I worked as a community alcohol nurse back in the 80s and 90s, we were doing sessions day in, day out in alcohol surgeries. That just doesn't, or it happens very infrequently now. But there's also been a huge reduction in the wraparound community support. You know, when I started working the alcohol field back in the 80s, and I don't want to just reminisce, but you know, there was a women's alcohol service, there was a residential long-term service, there was a drop-in centre for people with alcohol problems, there was a detoxification service, all provided by different providers working together. You know, those days are long ago and we'll never get back there, but we do need to look at how we link into our wider networks. Kate, do you want to add anything in here?
I guess it's really just, as we said earlier, with the long-term plan, the recognition that alcohol use is one of the 5 contributors to early or premature death, according to the Global Burden of Disease. And, you know, in terms of that interface with the wider health economy, the role of the long-term plan, the role of wider NHS services, it's clearly acknowledged that that needs to include the role of local government. And I think a challenge, I guess, for the commissioning and funding changes that we've seen since 2012 Health and Social Care Act is how that has resulted in quite a change in clinical treatment for people with alcohol dependency. I guess if we look at it in the wider round of other services such as smoking cessation, sexual health services, also provided through the public health grant, what we do know is that whilst there is a role there in smoking cessation, if you do actually have a clinical condition such as lung cancer associated with smoking, then it is picked up and treated through a different pathway. And I think this is a really big ask, that everything is done under this banner of the public health grant. And as I say, I think that has resulted in those reduced links with primary care. It's not something that we're hearing about particularly with the new primary care networks. I think, you know, we can certainly see pockets of good practice. And as you said, Kieran, the focus of the Dame Carol Black, which at the end of the day was a review of drugs, she did really try to pick up the issue of alcohol. She did try and pick up on the reduced skill set of the workforce. But again, I think the challenge is that any sort of competency framework really does need to be addressed a bit more seriously. When you look at comparable services such as IAPT that have very clear specifications for workforce competency, for evidence-based therapies, what we have is, I guess, commentary within NICE, which talks about the need for the need for the workforce to be appropriately trained, but it doesn't specify what do we mean by that appropriate training. It doesn't specify what the expected level of competence and qualifications would be. And I think the demise of the National Treatment Agency as an overarching national body has also had repercussions on where we are now. And it's to be hoped that with the move of PHE into the Department of Health and Social Care under the Chief Medical Officer, that we can start to redress some of that, which hopefully will have an impact on the mortality rates that we're just seeing going up and up with the more complex presentations, that not just the loss of detox beds, but as you said, Kieran, the complexity of patients when they actually get to detox, the comorbidities, that if you know, as a manager of one of those few remaining NHS units, if they would see outpatient unit, they would be system and strategic leaders to work together to respond to this significant agenda of mortality.
Thanks, Kate. Safar, could you move us on to the next slide? For me, it's, you know, unless a commitment is made, there are only promises, hopes, but no plans. I think that's where I feel we are at the moment. I would like to see a very clear national alcohol strategy for how we're going to move these things forward. You know, we've been promised a national alcohol strategy, which was due to come out in 2019. I'm not sure we're any closer to it. I think there's now talk of a national addiction strategy, where I am worried that the alcohol focus will be further diluted. But commissioning needs to be better integrated with stronger links to health via integrated care systems or primary care networks. But there's real challenges there. You know, I'm conscious that you know, we were involved in some areas in the mental health transformation rollout, and again, that was led by health services. And in lots of areas, they didn't involve the local authority in the mental health transformation rollout. And similarly, with Dame Carol Black monies coming through, there was very poor integration with health in regard to how we utilize those monies. So those key links between health and local authority in regard to integrated care. I think it probably works in some areas better than others, and I'm sure there's people in this call will be able to point me to areas of really good practice, which I've no doubt there is. But we're talking broadly, in most cases, it's not as good as it could be. I do also think there should be minimum standards for commissioning alcohol provision. There should be a very clear, this is what should be on the table when alcohol services are commissioned as part of an integrated care system. Kate started to talk about well-trained and supervised workforce delivering evidence-based interventions. It is vital. And at the moment, that is something that requires attention. She talked about the IAPT model. I moved out of addiction for a number of years into the IAPT, and was very clear that there's a lot that we can learn in the addiction field from what they've done in IAPT around training, supervision, case management, and when people were coming into service, they were very clear what they were going to get, why they were going to get it, how long it would last for. But in regard to alcohol treatment, it is cost effective. The PHE estimate that there's a £3 return for every £1 spent on treatment. It's both. We know it works. We know it's effective. We're just not doing it in a well enough structured and coordinated way. And I think with some degree of oversight and support, we can move to a better model of delivery. Kit, do you want to add anything?
Not really, Kieran. I guess just to highlight those minimum standards, again, sorry to keep bringing it back, but I think it's important that we do recognise some of the wider documents, such as the long-term plan, that can really be a bit of a vehicle for driving through some of this agenda. And there is no mention in the long-term plan of dual diagnosis, but what there is mention of is the alcohol care teams, with the expectation of preventing up to 50,000 admissions over 5 years. And I think what we can certainly see across my region is significant inconsistency in the delivery of alcohol care teams. And I think, again, it's examples of fractured silo working, and I'm absolutely sure that there are models of good practice. We're all involved in them, but the lack of ability to share that and have a baseline minimum standard is something that we really do need to be lobbying for. This, I think, has been in response to Carol Black Part 2 review of drugs, which immediately resulted in the announcement from the government of a drugs unit. So again, very much linked to the crime agenda, which I think for those of you that are at the Addiction Provider Alliance conference later this week, will really pick up on the impact of that on stigma across the sector. Thanks.
Okay, Sapphire, if you can move us on to, this is very much, if we were going to do a good alcohol service, what would it look like? And people know a lot of this stuff, but we do need to look at an open access referral system, which would take phone referrals, both from individuals and from professionals. But, services should then have dedicated websites where people can go online, refer themselves, but also get some of that early intervention work. And again, this is one of the things that we're working on very much in our services, is around that online offer. And again, this is something that's widely used in IAP services, computerized CBT. And, there are computerized CBT models for people who have mild to moderate alcohol problems, and we need to make sure that they're available, accessible, and on the front line of treatment. We talked about the need for workers to have a qualification, supervision, and case management, and I know there's work going on around standards, both for commissioning, but also for standards around qualifications and competency frameworks. But again, it feels as if we've been working on these issues on and off for years. It would be good to complete and have them worked through and running across all services. I've talked about this before, workers linked to primary care, supporting brief interventions and providing brief treatment. Our lack of integration with primary care, and I know it happens well in some areas, it doesn't happen as well as it should be. across the country. The link into general hospitals, it's fragmented, and what we've seen is that there will be projects and there's funding for a couple of years, and these things will run for a couple of years, and then when commissioning changes or services change, stuff that was there and working really well falls off again. So we know that there's some really good models out there which people are proud of, and they should be proud of, and deliver really good interventions, but they should be consistently delivered over a long period of time, not come and go. Workers linked into general hospital, clear pathways within patient community mental health services, our links with mental health services, again, are variable, and we're conscious that colleagues in mental health are really struggling at the moment. They are, and we sometimes feel as if they are focusing on their needs and don't very much look at what the needs of people with addiction problems are. We do need to have a very clear evidence-based trauma-informed talking therapies available as per IAPT. We need to build our peer support mutual aid around the services that we deliver, and we need to have very clear detoxification pathways, both to inpatient and community detox. You know, knowing what a good alcohol service looks like isn't rocket science, but how many services have all of them elements functioning well and supported with wraparound provision? It's something I think that should be available in all areas. Again, Kate, anything you want to add here?
I think really just emphasising what you've said about the links to primary care. I do wonder how it feels from a GP perspective. I'm not sure whether we've got any GPs with us today, but it's certainly, as somebody who worked out in the community from the mid-1990s, it felt as though there was a closer connection with primary care then compared to now. And I do wonder whether we have become too separate, too siloed, and maybe too specialist. I think, you know, focusing on services rather than the individual needs of the service user. I do wonder. I think, as somebody with either concerned about your own drinking or that of somebody that you care about, I would imagine that the first place you're likely to go to is your GP. So I think we'll have to absolutely get that support embedded and linked up and better. I think
you're right, Kate. It isn't just services for individuals, services for family need to be woven through this also. Sapphire, I'm conscious of time. Do you want to just move on to the final slide? Again, I think we are where we are with this. We need to build and deliver the best services we can. I think alcohol treatment is cost effective. We're just going to talk about some of the stuff that we do. And the reality is I could go out to services out there. I know that there is elements of brilliant practice and happen out there on a regular basis, but we'll pick up a couple of offers, and I'll come back to things that we've been doing through lockdown, for example, is that, you know, because we couldn't get out, the people, we were using disposable breathalyzers as part of our community detox regime. We were posting them out to people, having carers doing them. So we do need to be innovative with this. One of the things also was we've been putting on bereavement support sessions for our staff, because in our services, we do experience a number of our service users die as a result, you know, while they're still in care. And I think there is, previously, if people were in services, they used to get lots of support from each colleagues, you know, during the pandemic, and I think it's getting better now, but people were often isolated, working from home, doing a lot of telephone calls, doing online stuff. So we felt it was really important to build in some support for staff, because they have struggled to deliver services during those times. I talked about the enhanced online offer, and we're in the process of, we've got funding through Aimee Carer Black Monies to set up an NHS inpatient detox facility in the South Coast in Ferrum. So we're hoping to be opening that early in the new year, which is the first NHS inpatient detox which has been set up in the UK for many years. I suppose one of the things I would say is that we're struggling to recruit nursing staff at the moment. We have a number of good nurses lined up to work on it, but if anybody does fancy working down the South Coast and our nurses, you'd be more than welcome to give me a contact. We're really looking to build up a skilled and effective workforce there. Kate, do you want to talk a bit about radar and some of the other elements that you're involved in?
So for those of you not familiar with radar, it's a rapid access to detox, acute referral pathway at the Chapman Barker unit in Manchester. It's 8 collaboratively commissioned beds through the Greater Manchester CCGs to take referrals directly from the A&E departments across Greater Manchester. And what we recognised was that there was a treatable moment that people were presenting at A&E, usually with alcohol-related seizures, self-harm, falls. There is an independent evaluation of radar done by John Moore's, and hugely successful completions, over 90%. And it's about responding to that treatable moment. We found in the first year that more than 50% of the people coming through had no previous connection with alcohol services. And I think this connects back to what we've been talking about in terms of treatment services feeling as though they have something to offer. And I think that interface with A&E suggests that they don't. And that's been a direct response to using radar as a tool, really, in the armoury across GM to reduce alcohol-related hospital admissions. And I'm just very aware of the time. I can send more information out about that for anybody that wants to hear about it, but it's a great opportunity to do something collaborative, I think.
Thank you both, Kate and Kieran. That's a great rundown. Pretty much looking at where we are. So what I'm going to do now is I'm going to hand us over to Aimee, who's going to talk about her experience of going through an alcohol treatment. And then at the end, we will come back and we'll pose all those questions, which you will be putting in the question and answers box to Kate and Kieran and Aimee. Thank you.
Hi, thank you so much. So I guess like anyone's kind of addiction sobriety journey, mine kind of stopped and started. So December 2019 is definitely when my drinking was probably at its worst. And it was then that I decided to go to my GP. I was having a lot of mental health problems anyway. My anxiety and depression was really bad at that stage. So I decided to go to my GP and just explain kind of how I was feeling and just to find out what support was available. They referred me there and then to Forward Leeds, the GP that I was with. She was really sweet, bless her. She sat with me. She basically did the referral form for me. And then it was really quick that I was contacted by Forward Leeds and went to my first appointment. It was actually beginning of January at that point. So I'd gone to my first appointment and I was offered a pregnancy test there. I then found out that I was pregnant. So obviously I immediately stopped drinking anyway. And it was like all of those addiction problems had just completely gone away and I was just going to be sober and everything was perfect. And that was it. And that was life. And then beginning of March, I then had a miscarriage. And obviously this was just around the time that COVID was happening as well. So I then had a miscarriage and kind of I'd had a couple of weeks after the miscarriage of trying to remember not to go back into those habits of drinking, but very quickly, because I was obviously upset and we were going into a lockdown as well. So I was away from all of my friends and family. I live in Leeds and my family and friends are all back in Peterborough. So I was very much isolated at that point. And then before I knew it, I was drinking the exact same way as how I was before my pregnancy. And I think what was so dangerous at that point was because I'd had time off from drinking, my tolerance was so low, yet I still thought that I was able to drink as much as what I was previously. So there was two concerns. One, I found that when I was drinking, that's when my depression was worse. I was definitely suicidal, but only when I was drunk. When I was sober, I could definitely work through my feelings and just accept that I was sad and try and get through it the best that I could. But then as soon as I had a drink, I was suicidal and that was it. And then there was a particular time where I drank a lot and I woke up and I'd obviously been sick in my sleep and not woke up, and that terrified me. And I think with it terrifying me, I then realized that I wasn't suicidal. I didn't actually want to die. I just needed I needed to have a different life. Luckily, a lady who I was working with at Forward Leads had called me to see how my pregnancy was going, just as kind of a check-in, because obviously we'd stopped working together when I was sober and pregnant. She then called me just on the off chance to see how things were. And it was then that I told her that I'd had the miscarriage and that I wasn't in a good way. And then we decided to work together. Obviously, because it was lockdown, we weren't able to do face-to-face conversations or anything like that. So it was just over the phone, telephone appointments. And we worked really well together. I think I had probably 2 weeks of sessions. So it was an hour and a bit a week where I continued to drink and just kind of reduce it, because obviously I was drinking a lot. So it would have been irresponsible and dangerous for me to just stop straight away. So we worked together. And then on the 5th of May, 2020, I'm losing track of years now, 2020, that was when I stopped drinking. And yeah, it would be unrealistic to say that straight away all my mental health problems completely disappeared, but they have got so much better. There's so many things that I enjoy now that I definitely didn't think that I would enjoy before. And there's so many more coping mechanisms that I've learned, whereas before it was just self-medicating. That was the only thing that I really knew to how to deal with anything. So yeah, I continued to speak with Forward Leads, and I think what was really helpful was that they had a program after your initial 6 weeks of going through the abstinence program, I guess. And then after that, they have something called 5 Ways, and it's where you go and you can do classes. You can learn a lot about addiction, a lot more about the science, I guess. And that really helped. That's helped me to certainly stay sober. And it's helped me to kind of understand the dangers around it, really. And especially and the lack of tolerance that I had when I had my miscarriage and stopped drinking, just understanding how dangerous it would be to then go back to that same place as what I was before. But it's so, you think that you can have a bit of moderation, but I think as soon as you start having those drinks, it's so difficult to keep moderation at the front of your mind, because especially for me, I was only bothered about getting another drink, not really thinking about drinking responsibly, even though it's on the bottles, but we don't listen. So yeah, and then I continued to work with 5 Ways for about 12 weeks. I went through a program with them, and that was, some were face-to-face, some were over Zoom. And that was basically just learning more about addiction treatments, what's available, obviously not just alcohol, but drug-related addictions as well. And yeah, I think that really, really helped, having that little bit extra and that focus to kind of stay sober, and the knowledge of how dangerous alcohol is, I guess. So yeah, that's certainly helped me. I do think there's a concern that from a GP perspective, there was no kind of follow-up. I was just sent to Forward Leads and then assumed that everything's okay. I do appreciate that it's probably unrealistic to say that a GP is going to call to double check how things are going, but I do think that there maybe should be some kind of follow-up, just so that it's on record, I guess, to see how I am and how people are after they've had the treatment. But yeah, that's just my experience. So thank you.
Thank you, Aimee. It's so good of you to come and talk to us your experience today. And on what was on the whole a reasonably positive experience, but I can't help but wonder that some of that was almost by luck than judgment. And and I think it's so important that the Forward Leads worker phoned you up just to see how you are. And I do feel that these positive examples of kind of every contact counts, where actually what we say to people, sometimes even almost in a throwaway moment, can have a massive impact. And going back to what Kate and Kieran were talking about before, obviously there needs to be a strong focus on people with very advanced disease and who are very, very poorly. But I can't help as a GP think over the years, everybody I saw who was alcohol dependent at one point saw me and wasn't. And, how many interventions earlier on may have had positive impacts on people's lives and stop some of that progression. So thank you very much for that. And I'm going to go through the questions now for everybody. There are masses, so which is not surprising. If we don't get yours done, I apologise. A couple of things, Kate and Kieran first. We've had people asking, could you have your contact details? And if you feel comfortable with that, can you pop that in the chat? And then if we can get you with your cameras on as well, Kate, we can then go through some of the questions we've got here. So an interesting one, this has come from somebody who works with the police early intervention and prevention unit. How do we best empower our communities to understand the impact that alcohol has, and what evidence-based interventions are out there for early stages, rather than waiting until people are dependent, obviously given all the good work Radar is doing with people as well. And and how does that sit with the cultural embedment, if that's a word, that alcohol has in our society?
Can I just start on this one? I think there's really good evidence for early interventions around alcohol using brief interventions. And I think that works in a number of settings. It certainly works in the criminal justice setting. I think we do need to build in an infrastructure to support that. We're actually just rolling out a pilot at the moment of it's work we're doing with a company called Silver Cloud, who provide a lot of the IOPT models. We're developing an online treatment option for people in the early stages of the criminal justice system. So we're doing some work with that and with a number of police commissioners in different areas, and we're hoping to have some good evidence from that in the next period of time.
I would just add to that. For me, it's about reducing stigma, and I think that we could learn a lot from I suppose the progress that our mental health colleagues have made over the years of it's okay to not be okay, it's good to talk, all the initiatives that we've seen around suicide prevention and promotion of coming forward to seek early help. I do think that we need something similar around alcohol being, the biggest, most used drug across the population, but something that still remains incredibly socially acceptable. And I think, as we said earlier, it's not criticism, but it is observation that connection with the drugs and crime agenda, I do think has had a consequence on how that is received perceptively across communities. So I think we probably need something far more focused. It's the sort of Stoptober and sober, what they call dry January. They can be helpful, but I think in terms of people that really are struggling with alcohol dependency, they can be something that is not quite enough.
Okay, and some of the other questions sort of feed into this. One obviously is more of a comment, but it's the fact, obviously there's a strong evidence base for brief interventions and IBA, and yet there's also often a feeling that this should be delivered in healthcare settings. So how do we perhaps, and this is with the Public Health Act really, how do we get other people and other professionals and other people from other backgrounds delivering IBA, and also then moving on from that, does the development of primary care networks offer a potential improvement in integrating alcohol services?
Yeah, I think we would really see that the development of primary care networks would be an ideal place to integrate those services for people experiencing primary alcohol problems, but also associated with mental health distress and the need for access to talking therapies.
But just to reinforce what Kate was saying, I do think primary care networks provide a significant opportunity. However, again, they need to be, primary care networks can't just sit in isolation. They need to be linked into integrated care systems. And, the evidence recently around mental health transformation monies, the Aimee Carer Black monies, we need a reset. You know, if we keep on doing the same things as we've been doing, we're going to get the same results. There needs to be a reset, and we need to ensure that the right people are around the table and that the resources are directed to where they're going to be the most effective.
Yeah. I can't argue with that at all. I think I still dream of the day when GP commissioners and public health sit around and co-commission decent drug and alcohol services, rather than trying to decide that it's each other's business and then we can just blithely ignore it. And I realize, you know, as a working GP, that, you know, it is hard work and it isn't part of our regular contract. But if we're prepared to pick up the pieces of the broken lives by alcohol, I actually think we might actually work slightly less by investing a little time in people earlier on. But as one of the attendees made the point, actually, you know, some people will feel stigmatized going to their GP. And it'd be interesting to ask, Aimee, was that anything that crossed your mind, that you might feel stigmatized by approaching your GP, or was it very natural, just that's where I went?
It was very natural. I think my GP was very young, and when I walked in, I thought, no, I'm not going to say it, because I felt that it was more embarrassing speaking to someone kind of my age. But then I just said it. So that was kind of the only thing that I felt, a little bit uncomfortable about. It was more going to the recovery centre and waiting. You had to buzz to be let in and waiting outside. That's where I was so worried, because I felt that people were going to walk past and see me and judge me straight away from being stood outside that door. That was kind of, that was definitely where I felt more judgment. I think when it comes to your GP, you feel that they have to help you regardless. And that's why I felt more comfortable going to my GP straight away. And I didn't really entertain I just didn't even think about going anywhere else. It was just straight to my GP.
Yeah.
Well, I do think we do need a number of pathways into addiction services, and I think GP is an absolute crucial way of that, but we do need to enhance our primary care access, mental health, general hospital networks. But I do think for a lot of people who are unsure, I think people are more used to getting their care delivery needs met online, and will go on and do online assessments than were a couple of years ago. And I recognize that this is not for everybody, and you know, it should not be the only option. We need to have a range of pathways, but there's no doubt for some people, going on, putting information in, doing some assessments, and maybe having some telephone contact can be a really good way to get in. But I have to say, it is not for everybody. We do need a full range of pathways into services.
Also, if I could just say, I mean, I was very lucky with the timing that it was pre-COVID, and I was able to get an appointment with my GP fairly quickly, because like any addictions, you have to strike while the iron's hot. As soon as you want to get help, I think it's very important to get help relatively quickly, because that thought process tends to go. And then before you know it, you're not at the point where you're looking to seek help. So I do think it's the timing as well that is so crucial with these things.
Absolutely, Aimee. Thank you for that. And I agree that the problem is provision is very patchy. So you can go to one GP practice and you'll be dealt with, you know, compassionately, and they'll be interested in your problem. And you may go to another and they just don't have the same response. And I think that must be very disheartening for those people who've actually, you know, plucked up the courage to go down there and to start to discuss this. And so I definitely agree with Kieran that having multiple ways in is ideal, but I think we also should be pursuing and driving for sort of minimum standards of knowledge and care. You know, I have medical students who, you know, have no idea about how to do an assessment around drugs or alcohol, and yet they could, you know, knock spots off me doing a cardiovascular exam. So I think, you know, how do we get some of those minimum standards? And that featured into another comment, which is really probably for Kate and Kieran, which someone's saying, is it time to update the DANOS framework?
I certainly think that we need to review a competency-based framework. I think DANOS provided a lot of useful structures, and I think whatever is going to be developed won't look massively different from DANIS. But I think where DANIS sometimes fell down, and if you look at IOP stuff, is supervisory frameworks need to be in place. Interventions need to be very clearly prescribed. You know, that there is a very clear treatment modalities, because sometimes what you get when you go along to addiction, for example, what you get when you go along to IOP service is very clear. You know, if you come along with this condition, you get this treatment. If with addiction service, often what you get depends on the person you see, and there should be a very clear treatment pathway where people get specific interventions, evidence-based interventions at specific times, and they need to be properly trained and supervised. And I think supervision is one of the things that absolutely needs to underpin this, and that should include case management as well.
Okay. Yeah, and I think alongside that, one of our attendees has made the point, you know, what happened to no wrong doors? And I think that's right. You know, we do need to have, you know, that openness, that when someone presents to us, even if we're not the right service, we don't just send them away and say, you need to go somewhere else. We've got to try and work amongst ourselves and be far more integrated, you know, than we have been, I think. And that's something that primary care, I think, used to do well, but has struggled with more. One question here, and this is for you, Kate. I think, are there lots of plans to roll Radar out across the country? Are you aware of at all?
No, I think it's a very localized issue. So we were able to start Radar. I think we started around about 2012 through some old strategic health authority pump prime funding. So, the whole point of it being CCG funded is that it's about preventing an admission in the acute hospital trust. So the eligibility criteria for Radar is that unless that person is going to be admitted to the general hospital, they wouldn't be eligible for Radar. So I think in terms of, I certainly know that there's been interest in Radar in other parts of the country. And I can see that there's quite a bit in the chats. If people have got my email details, I can certainly point them in the direction of the Liverpool John Moores independent evaluation. And I do think it's something that is worthy of consideration, but I think it would need to be through your local health economy rather than your public health teams.
I just have to add there, I had the good fortune to go and visit Kate's unit recently and visit CBU and the Radar unit, and some of the work they're doing is outstanding. It really, really very impressive. And I think other parts of the country would be absolutely crying out for that type of provision.
Okay, thanks, Kieran. Thanks, Kate. And just someone's question. Yes, you can. This is being recorded, and the recording will be available to you after. So if you use if you log back in, you will be able to watch it again and see all those slides and presumably take screenshots or whatever you need to do with them. Kieran and Kate, I'm sure, won't mind too much. And I'm sure the ONS won't either. There's a question here about with Radar. Do you limit the number of detoxes that people get in a particular time frame, Kate?
So it's a 5 to 7 day. It tends to be a 7-day admission, and because there are 8 beds commissioned across the Chapman Bark unit is 36 bedded, so 8 of those are reserved for Radar. So you know, that's worked out between the 10 Greater Manchester CCGs in terms of their funding commitments. What we were able to do during COVID was to flex up to support the pressure on the A&E departments, and that was that was really well received by our acute colleagues.
Okay, and if someone came in and went through the Radar process and were back in 3 months later, would you do them again, or would you go, oh, that's, you know, it's you again?
They would be considered, and it has happened. We have had multiple attenders from who've been through Radar before. It would be, I think, something that we would need to, because you'll be aware of the kindling effect of continual detox is not good either. So it would be something that would be considered clinically.
Yes. Okay. And there's another question here saying, obviously we've had that 20% increase looking at the first 3 quarters of 2020, and I'm fairly certain it's not acute presentations and deaths. What do we feel is feeding into all this, and do you see these trends increasing?
I think there's absolutely no doubt they'll increase unless we take a more systematic and proactive view in regard to both how we manage alcohol as a society and how we manage alcohol as a health and social care infrastructure. Sadly, for me, this is a public health crisis. This is if this was any other area of healthcare and we were seeing these numbers, people would be jumping up and down, and there would be parliamentary groups and there would be action happening. I think this goes back to that stigma issue and people's prioritization and the deserving and undeserving in regard to health and social care. So unless there is significant changes in how we respond, I think the outlook, I can't see any light at the end of the tunnel for this unless things change significantly.
Yeah.
Yes, I do think there is almost isn't there? I get the feeling people feel, oh, it's a lifestyle choice, with drugs and alcohol, and people don't at the above commissioning level at government or whatever understand the deep-rooted distress that often drives people to end up in this situation, and how important our interventions can be. And I don't hear as much talk about trauma-informed care around alcohol as I do around substance misuse, which seems strange to my mind.
But this is all, for me, the background, this is health inequalities. And, we do need to look at having, I think an alcohol strategy should be part of that, but we do need a health inequality strategy, which looks at everything from, again, we're in a situation now where, the resources that are going to families is reducing. It's not a good time when health inequalities get exacerbated. People's well-being declines, and I think there's steps that we can take to change that, and I'd love to see some of them changes being made.
Okay, and then one other thing is that, and that's coming through quite strongly on here, is obviously the role of peer support and sort of voluntary organisations outside. And I actually think particularly in a primary care setting, there's often not a real connection between 12-step or SMART or whatever, whichever services are available, and the way people operate. And I think, I've always said we need to sort of proactively involve people in peer support and recovery at the outset, not wait until they've finished the process. So any thoughts about how we might be able to sort of better link that, given the fact that we have such financial pressures on us, and that we're talking long-term behavioural change here, how that's best supported, which is probably within the community.
Yeah, can you hear me okay? I'm so sorry, my internet just keeps coming and going. I think what I would say is, when we've talked about the impact of integration, I think the recovery communities have actually benefited from integration. And I think that certainly across my community service areas in Greater Manchester, we've got some real great examples of things like recovery choirs, which, those that participate in those types of activities would say we're all recovering from something, and that has been that sort of example of inclusivity has been really welcomed and really opportune for those recovery communities across those localities. I'm not sure that once somebody's entered into a recovery lifestyle, that it is necessarily needs to be substance specific. That makes sense.
I do think mutual aid and peer support should be woven into. We need to take an asset-based community development model approach to this. And again, there's examples of some great asset-based community development services out there, and they should become the bedrock for that integrated care that should happen. It should be everywhere. And again, there should be pathways right throughout our health and social care systems.
Good. Okay. And I think this point here is again, and this has come up. This come up so often, is the number of people who are suggesting that there's a kind of hierarchy even amongst people with problems, and that some people feel uncomfortable going into a building that does opioid substitution therapy if they've got an alcohol problem, vice versa. And yet there are people who've got joint problems, so I presume we're not going to be able to have an opioid specific or crack specific service, an alcohol specific service, a both service. How do we make the best of what we've got, and how would you sort of envisage that working in the future? Because I think alcohol, it's not even I don't think calling it a Cinderella service is even fair. I'm not sure it's even that well represented at the moment. So is it purely funding?
I think there's clearly in integrated services, there's some real areas of good practice, and where they have very clear and specific alcohol pathways, which allow those who have distinct alcohol problems to move down that pathway and get the treatment support that they needed. Sometimes people with alcohol problems fall into drug treatment pathways, and they end up getting the wrong type of treatment for the wrong duration of time. With alcohol treatment, it needs to be very goal orientated. It needs to be very change based. You're not trying to maintain them in there and keep them on a script. And sometimes I think people do get the wrong interventions. But as I say, there's some brilliant pathways out there, but I think we need more specific alcohol treatment pathways, and that would stand the same for crack and things like that there. But there is a resourcing issue, but there is also a system issue, and I think we should get the system right more than we get it wrong. Additional resources would help.
Okay. Thank you. And then just one final one this will be the last one, I'm afraid, everybody, but it's been absolutely amazing seeing all your comments particularly on the chat, which has been absolutely buzzing today, which is great. So I think, are you aware of any sort of online support for people who have issues with the drinking that perhaps GPs could refer into at a much earlier stage? Or is there anything that you'd recommend, or is that something we need to develop and get equally shared out amongst primary care?
I think there's a couple of good national models. Things like Down Your Drink are very useful tools to do that. The Alcohol Learning Centre is a link to some very useful resources as well. So I think there's some good stuff already there in primary care. I know lots of services are developing their own online offers, but Breaking Free Online also do a very good alcohol offer. As I say, we're doing work with a company called Silver Cloud at the moment who do the IAP stuff around developing an alcohol Silver Cloud offer. And within that, they also offer debt management, sleep, hygiene. There's a whole range of health and well-being things. So there's lots of really good online options out there, which are free and easy to access. It's good if some are linked into services. You then can get that therapeutic. From an IAP perspective, one of the things I think works really well with CCBT is guided self-help. So whether that's through some sort of web chat system, or we would have conversations with someone once a week. They would set themselves work to do on the app, and then you would have regular touch bases around that. So there's different models, and it's about getting a model that works best for the individual.
Yeah, I agree with that. And IAPT is a good sort of way of looking at it. But you see, in the CCG that I'm in, we have an IAPT service, and see people can self-refer to it, or they may come and talk to me, and I feel they may benefit from it. And there's the one model. Whereas with alcohol, people may find these services for themselves, and they come and talk to me, and then I have to say, oh, well, you could try this. There isn't anything that's commissioned, you know, through the CCG or the PCN that's available and sort of standardized. And I think you made the point about when you present to an IAP service, there's a very specific treatment pathway. And I just think this is, you know, this disparity between what you get, you know, postcode lottery probably is the term people use, is one of the major stumbling blocks that we currently have. But that's my rant over. You don't have to say anything, Kieran. Okay, right. I'm gonna wrap this up now. We could probably go on most of the afternoon, but some of us or some of you will have lives. Mine's just all around webinars. And thank you very, very much. And I know you will want me to give your thanks to Kate and to Kieran, and especially to Aimee, and also to Kate Halliday and Sapphire Nichols behind the scenes, who've helped to run this, to our colleagues at DDN who've supported us in doing this. And as I say, hopefully this is the start of move forward into try and address these issues and to improve these services. And certainly from the enthusiasm that all the attendees have shown, I think we actually might have a chance. Thank you, everybody.